All right, let's jump right into this massive NUR 104 Exam 4 study guide and turn it into a streamlined, high-yield explainer. I know, looking at a list with over 30 bullet points can feel incredibly overwhelming, right? But don't sweat it. We're going to go point by point, breaking down exactly what you need to know and handing you the direct answers for every single concept so you can absolutely ace this test. To keep things super efficient, we've chunked your study guide into 5 main buckets: arterial disorders, venous disorders and hypertension, hematology and anemias, coagulation and blood cancers, and finally, key nursing interventions. Let's hit the ground running with our first system. Section 1. Arterial disorders, perfusion, and blockages. So when we're talking arterial disorders, perfusion problems usually kick off with hardening and blockages. Your study guide specifically asks for the pathophysiology of atherosclerosis and peripheral artery disease. Well, think of it like this. It all starts with some kind of blood vessel damage that triggers inflammation. A fatty streak covers up that inflammation, and then collagen builds up, hardening it into a fibrous plaque that literally blocks your coronary blood flow. And since this is the #1 risk factor for cardiovascular disease, you've got to remember to monitor those lipid levels. Keep the LDL and triglycerides low, and aim for a nice high HDL. Now, that systemic atherosclerosis directly causes peripheral artery disease, or PAD, which progressively chokes off blood flow to the extremities in 4 distinct stages. Stage 1, it's asymptomatic, just decreased pulses. Stage 2 is claudication. That's muscle pain or cramping that hits when they exercise but goes away when they rest. Moving to stage 3, we have rest pain. This often wakes the patient up dead in the night, and they'll usually describe it as a burning or toothache-like pain right in their toes. Finally, stage 4 brings necrosis and gangrene. We're talking blackened tissue with a really distinct odor. Naturally, all these perfusion issues lead to ulcers. And for your exam, you absolutely have to be able to tell the 3 main types of lower extremity ulcers apart. Arterial ulcers feature that claudication we just mentioned. The foot will feel cool with decreased pulses. You'll see dependent rubor, that deep red color when the leg hangs down, and the ulcers usually pop up right on the ends of the toes. Venous ulcers are a whole different story. No claudication here. They feature moderate discomfort with swelling, specifically right around the ankle, and pulses are usually totally fine. Then you have diabetic ulcers, which present with peripheral neuropathy, typically right on the bottom of the foot with pale, even edges. Just look at the stark visual contrast here. On the left, you've got gangrenous toes from an arterial issue. Notice that purple and black discoloration right at the tips of the digits where the blood literally just cannot reach. But on the right, that's a classic venous stasis ulcer. See how it's parked right on the ankle with that brownish skin discoloration all around it? Lock that visual in your brain because it is guaranteed to score you a point on test day. All right, another huge arterial topic on your guide is aneurysms. These are permanent, localized dilations of an artery, most often caused by our old friend atherosclerosis. And they present completely differently depending on where they are. A thoracic aneurysm, that's going to cause back pain, shortness of breath, and hoarseness or trouble swallowing. But an abdominal aortic aneurysm, or AAA, presents with a steady, gnawing abdominal or flank pain and a telltale pulsation in the upper left abdomen. Now listen closely. If you see that pulsating mass, your absolute nursing priority is to never ever palpate it. Why? Because a rupture leads to massive hemorrhage and hypovolemic shock, period. Section 2, venous disorders and hypertension, return and pressure. When evaluating systemic blood pressure, you really need to know the complications. Long-term, uncontrolled hypertension is no joke. It can lead to strokes, heart attacks, and kidney failure. Controlling modifiable risk factors like smoking, obesity, and sodium intake is how we prevent these. But if a patient's blood pressure spikes dangerously high, we're talking over 180 over 120, you have to know the difference between an urgency and an emergency. If they are totally asymptomatic, it's a hypertensive urgency. Just restart their oral meds. But if they're symptomatic, complaining of a headache, blurred vision, or shortness of breath, bam, that's a hypertensive emergency. Your immediate goal is to get them IV medications to drop that mean arterial pressure by 25% within the very first hour. Moving back to the veins, if you have a patient come in with unilateral calf swelling, warmth, and tenderness in the groin or calf, you should instantly suspect a deep vein thrombosis. Your interventions here are super critical. Elevate the affected leg while they're in bed, apply warm compresses, use compression stockings, and administer anticoagulants. But here is the massive safety check for your exam. Do not massage the affected limb. Seriously, no massaging. You could dislodge that clot, send it straight to the lungs, and cause a fatal pulmonary embolism. Let's quickly pit 2 specific peripheral vascular diseases against each other. Both Raynaud's phenomenon and Berger's disease cause severe peripheral vasospasms, literally turning the patient's fingers or toes blue or white. But here's the key distinction for your test. Raynaud's is triggered by cold and stress, so your teaching needs to focus on wearing warm clothes and managing that stress. Berger's disease, however, is heavily tied to smoking. Because of that, smoking cessation teaching is your absolute #1 priority for a patient with Berger's. Section 3. Hematology and anemias. Blood components. Okay, shifting gears from the actual vessels to the blood itself, let's talk oxygen carrying capacity. Anemia is simply a drop in red blood cells, hemoglobin or hematocrit. And you might be surprised, but the #1 cause of anemia in adults is actually GI bleeding, though it can definitely come from diet or genetics too. Because oxygen delivery is taking a hit, these patients are going to show signs like extreme fatigue, pallor, shortness of breath when they move around, and tachycardia. To fight back, the body relies on erythropoietin. This is a hormone produced by the kidneys that essentially acts as a massive cheerleader, stimulating the bone marrow to pump out more red blood cells. Now, for sickle cell disease, the pathophysiology you need to know is that low oxygen levels cause abnormal hemoglobin S to distort into this rigid sickle shape. These weirdly shaped cells get super sticky, clump together, and block blood flow, which causes severe tissue hypoxia. So the key takeaway here is that a vaso-occlusive crisis is incredibly painful. Your #1 top-tier nursing priority is pain management. We're talking IV analgesics for at least 48 hours. Once you've tackled the pain, your next moves are aggressive hydration to help unclump those cells, followed by oxygen therapy. On the flip side of the coin, we have polycythemia vera. This is actually a type of cancer that triggers a massive, out-of-control overproduction of red blood cells. Now, you might think, hey, more red blood cells equals more oxygen, right? Wrong. It's actually the exact opposite. The blood becomes hyperviscous. Think thick, slow-moving syrup, which totally wrecks its oxygen-carrying capacity. This leads to a very distinct set of symptoms: dark purple or cyanotic mucous membranes, intensely itchy skin, facial flushing, nasty headaches, and even gout. Section 4. Coagulation and blood cancers, clotting and WBCs. All right, let's dive into clotting mechanisms and white blood cell disorders. Smack in the middle of your study guide is this absolutely critical question. No matter what specific clotting abnormality your patient has, whether it's thrombocytopenia or they're just on heavy blood thinners, you have to know your fundamental overarching nursing priority. And the answer is simple, direct, and vital. Prevent hemorrhage and injury at all costs. This is the ultimate guiding principle for every single intervention we're about to cover. Looking at this crazy, complex coagulation cascade, don't panic. You don't need to memorize every single factor, but you definitely need to know your anticoagulation lab values to prevent that hemorrhage we just talked about. Remember, for a patient on an IV heparin drip, we are meticulously monitoring their anti-XA or PTT levels. If they are transitioning over to oral warfarin, we switch to monitoring the PT and INR. You're looking to confirm an INR between 2.0 and 3.0. Anything higher than that, and they are at a massive risk for uncontrolled bleeding. Let's quickly break down the blood cancers. Leukemia is a cancer of the bone marrow. It presents with bone pain, anemia, and paradoxically high white blood cell counts. But here's the catch. Those white blood cells are immature blast cells. They are totally useless at fighting infection, which puts your patient at a massive risk for illness. Lymphoma, on the other hand, is a cancer of the lymphatic system itself. It typically shows up as enlarged, painless lymph nodes, drenching night sweats, and weight loss. And a key test fact, if a biopsy of the node shows Reed-Sternberg cells, boom, that is definitively diagnosed as Hodgkin's lymphoma. Circling back to bleeding risks, thrombocytopenia simply means the patient has dangerously low platelets. We diagnose it with a standard CBC, and if those platelets drop below 10,000, you are almost certainly going to need to transfuse. To keep these patients from hemorrhaging, you have to be super aggressive about bleeding precautions. You've got to teach them to completely avoid aspirin or NSAIDs, use only a soft bristled toothbrush, shave exclusively with an electric razor, and absolutely no contact sports. Section 5. Key nursing interventions. Surgical and procedural. Let's consolidate the 3 major procedures that your study guide demands you know inside and out. For an abdominal aortic aneurysm repair, your post-op priority is monitoring their abdominal girth and blood pressure like a hawk, keeping an eye out for signs of a graft leak like bruising on the back. For discharge, make sure they know no heavy lifting over 15 to 20 pounds for up to 12 weeks. Next, following an arterial revascularization or bypass, you're monitoring for graft occlusion and compartment syndrome. But keep in mind, warmth and redness in that affected leg are actually expected. It means the blood flow is back. Lastly, for a bone marrow biopsy, you've got to prep the patient for a heavy pressure and a weird crunching sound during the procedure. Post-op, your job is bleeding prevention. Keep a tight dressing on it and inspect that site every 2 hours. All right, we have successfully decoded every single point on your study guide, handing you the direct answers and the physiological why behind all of them. So the final question I want to leave you with is this. When you walk into your next patient's room, how will you use this knowledge to spot the subtle difference between a routine symptom and a full-blown, life-threatening emergency? Remember, it always comes back to preserving perfusion and preventing injury. Trust your prep, take a deep breath, and go ace that exam.